Welcome to the Kanski lecture series, Cornea and Refractive Surgery Part 3, and in which we are going to discuss today about the keratoprosthesis and the refractive procedure. So let's get started. So what is a keratoprosthesis? So keratoprosthesis is when the cornea cannot be rehabilitated by the corneal um, transplant, like you cannot do corneal transplant in such cases, and the eye is healed and scarred, and there is a useful vision in the retina, but due to the corneal opacity, the patient cannot see, and you cannot do corneal transplant because of corneal vascularization, scarring, or multiple regions. Then you can go for keratoprosthesis. Keratoprostheses are artificial corneal implants used in patients unsuitable for keratoplasty. The modern osteodontokeratoprosthesis consists of the patient on tooth root and alveolar bone supporting a central optical cylinder and is usually covered with a buccal mucous membrane graft. Surgery is difficult and time consuming and is performed in two stages, 2 to 4 months apart. So what you do is you need basically an optical cylinder which will make the patient see, and how it is supported. You take an alveolar uh, tooth bone and patient tooth root, and the rest of it is covered in the buccal mucous membrane graft. So what are the indications of keratoprosthesis? Bilateral blindness from severe but inactive anterior segment disease with no realistic chance of success from the conventional keratoplasty, for example, Steven Johnson syndrome, ocular cicatricial, pemphigoid, chemical burns, and trachoma. So, when you cannot replace a scarred cornea due to a number of reasons, like the cornea is severely scarred, opacified, and the whole cornea is involved, then you go for keratoprosthesis. Visual acuity of counting finger or less in the better eye, intact optic nerve, and retinal function without marked glaucomatous optic neuropathy. So, why it is useful only in the patient in which there is the retina is intact and there is a useful vision in the retina. Otherwise, there is no use of the keratoprosthesis. High patient motivation. Complication include glaucoma up to 75%, retroprosthesis membrane formation, tilting or extrusion, retinal detachment, and endophthalmitis. Glaucoma management is inevitably extremely challenging. So one thing is you can get glaucoma, there can be membrane formation, the implant can extrude, intrude, there can be the retinal detachment and endophthalmitis as well. Result: approximately 80% of the patient achieve visual acuity between counting finger and 6 by 12, occasionally even better. A poor outcome is often associated with pre existing optic nerve or retinal dysfunction. So, retinal dysfunction, retina function, and optic nerve, intact optic nerve is very important in the case of the keratoprosthesis. So, you can see the keratoprosthesis here. You can see that this is an optical implant that is supported by the buccal mucosal membrane. Refractive procedure. So what are the refractive procedures? So basically refractive procedures are certain kinds of uh, procedures, surgeries you can perform in the eye to improve the patient vision. You can improve myopia, you can improve hypermetropia, and you can improve the astigmatism as well. So let's get started. Introduction. Refractive surgery encompasses a range of procedures aimed at changing the refraction of the eye by altering the cornea or lens, the principal refractive component. So what are you going to do? You know that cornea produce 3/4 of the optical power of the eye, and lens produce 1/4. So when you change the refraction of this refractive power of this, you can change the vision as well. Myopia, hypermetropia, and astigmatism can all be addressed, though correction of presbyopia is yet to be achieved on a consistently satisfactory basis. So only these myopia can be changed, but if there is a presbyopia, you cannot do much about it. Correction of myopia. So in a case of myopia correction, so what can you do? Surface ablation procedure can correct low to moderate degree of myopia. Laser in situ myelus LASIK. See below can correct moderate to high myopia depending on the initial corneal thickness, but for very high refractive error, one of the intraocular procedures below is necessary. So there are certain procedures. You can change the surface by ablating them. You can do a LASIK procedure. We will discuss this in the coming way. It is very commonly performed procedure nowadays, LASIK procedure, in which you change thickness of the cornea. You make the cornea a little, if there is a myopia, you make a cornea a little bit of thin to increase the refractive power. Refractive lenticule extraction is a newer technique for the correction of myopia and myopic astigmatism. Clear lens exchange give a very good result, but carries a small risk of complication of cataract surgery, particularly retinal detachment and individual with high myopia. So when there's a patient with having a very high myopia, like in a negative lens, then you can do clear lens exchange in the cases. Iris clips. Lobster claw implant is attached to iris. Complication include subluxation or dislocation due to dislodgement of one or both attachment, and oval pupil endothelial cell loss, cataract, pupillary block, glaucoma, and retinal detachment. So these are going to be the intraocular procedure. Basically, in clear lens, there is no cataract, there is no opacity, but you know that a lens is convex, and it uh, converge the rays. But when there is a very high myopia, then you what do you extract the lens and put the intraocular lens, which is of very less converging power, so that uh, uh, it can converge only on the retina. Phakic posterior chamber implantable contact lens. So it is just like the patient is having a contact lens on the lens. It is inserted behind the iris and in front of the lens and supported by the ciliary sulcus. The lens is composed of a material derived from collagen collamer with a power of -3 diopter to -20.50. Visual results are good, but complications include uveitis, pupillary block, endothelial cell loss, cataract formation, and retinal detachment. Radial keratotomy is now predominantly of historical interest. So let's see figures. So you can see 8.12. It's showing the phakic intraocular implants for correction of myopia. A is showing the anterior chamber iris claw implant with interior iris attachment and 3 and 9 o'clock position. So this is an iris claw. B is showing emplacement of the posterior chamber phakic implant between the iris and the interior lens surface. So this is basically the patient is getting the contact lens posterior chamber implant. And this is showing the radial keratotomy. You can see the incision marks on it. So now how we correct the hypermetropia. Similarly, surface ablation procedure can correct low degrees of hypermetropia. LASIK can correct up to 4 diopter. It is a very important MCQ question. How many diopters can a LASIK correct? So in a case of myopia, it is usually you can do up to 8 diopter, and in case of hypermetropia, you can do it 4 diopter. Conductive keratoplasty involves the application of the radio frequency energy to the corneal stroma and correct the low to moderate degree hypermetropia and hypermetropic astigmatism. Burns are placed in 1 or 2 ring in the corneal periphery using a probe. The resultant thermally induced stromal shrinkage is accompanied by increase in the central corneal curvature. Significant regression may occur, but the procedure can be repeated. Conductive keratoplasty can also be helpful for the presbyopia. Complications are infrequent. So what do you do is basically, for example, this is cornea. You ablate, you place a thermal energy in the periphery of the cornea. So what happens is that the center of the cornea become ectatic. When this become ectatic, then there is a correction of hypermetropia. Laser thermal keratoplasty with a holmium laser can correct low hypermetropia. Laser burns are placed in 1 or 2 ring in the corneal mid periphery, As with conductive keratoplasty, thermally induced stromal shrinkage is accompanied by the increased corneal curvature. Correction decays over time, but treatment can be repeated. So it is the same laser thermal keratoplasty. It's same as like conductive keratoplasty, but in this case, it is a holmium laser. That is holmium laser that is used to correct to place the burn. Other modalities include clear lens extraction, phakic lens implant, as described above for myopia, intraocular. Surgical procedures are the only options for high degree of refractive error. Correction of astigmatism. It is very important. Limbal relaxing incisions or arcuate keratotomy. So what you do is basically where there is a steep axis, you put the incision on that side. It will correct the astigmatism of that side. Limbal relaxing incision or arcuate keratotomy involves a paired arcuate incision on the opposite side of the cornea in the axis of the correcting plus cylinder, the steep meridian. The resultant flattening of the steep meridian coupled with the smaller steepening of the flat meridian, flat meridian at 90 degree to the incision reduces astigmatism. The desired result can be controlled by varying the length and the depth of the incision and the distance from the optical center of the cornea. So basically, arcuate keratotomy may be combined with compression sutures placed in the perpendicular meridian. When treating the large degree of astigmatism, such as occasion occur following penetrating keratoplasty. So one thing you should remember by remembering that, during a cataract surgery, if you know that cornea has some steep axis, you put your incision at that place, so it causes the flattening of that surface. So what happened, the incision causes the flattening of that meridian. So similar in the arcuate keratotomy, for example, this is a steep meridian and this is like a flat uh, oh, flat. So this is a steep meridian and this is a flat meridian. So in arcuate keratotomy, we give incisions at the steep meridian. So what happens, opposite side, and what happens is that it causes the flattening of this meridian and it causes the steepening of the 90 degree to the axis of this. So next is PRK, and LASIK can correct up to 3 diopter and LASIK can correct up to 5 diopter. So these are other procedure. Phototherapeutic radial keratectomy. LASIK can correct up to 5 diopter. Lens surgery including toric intraocular implant incorporating an astigmatism correction. Post-operative rotation of the implant away from the desired axis occur in minority of the cases. Conductive keratoplasty. So basically lens surgery, we can place the toric IOL. So what is a toric IOL? So toric IOL is basically like a cylinder type. At some axis it has a it has a power. You can give it like a hole. So you place it at the in the axis where there is a steep meridian. So you can see figure now 8.14 is a thermal keratoplasty. You can see the burns in the mid periphery and correction of astigmatism. So you can see the arcuate keratotomies, like you can see this toric intraocular lens implant in situ marking. So you can see the marking of the toric implant like this. So you can identify that this is a toric lens. Correction of presbyopia, lens extraction either to treat cataract or for purely refractive purpose. Acronym used for the clear lens exchange, refractive lens exchange, and presbyopic lens exchange. Much research effort are being applied to the development of effective accommodating prosthetic lenses. Implantation of multifocal, bifocal, or accommodating or pseudo accommodative intraocular lens implant can optically restore some reading vision. So basically, during aging, what happens is that due to the stiffness of the zonules, the lens do not uh, accommodate very well. So due to this loss of accommodation, there is a presbyopia. You cannot see clearly at near position. So there are some intraocular lens that are made to correct this position, like multifocal, bifocal, or accommodating lens. But reading glasses may have to be used for some tasks. Most recipient of the multifocal IOLs are happy with visual outcome. However, dissatisfaction may occur as a consequence of nocturnal glare and reduced contrast sensitivity, and around 10% subsequently undergo IOL exchange surgery. So basically, multifocal lens is that whenever you see at different distance, you have a different refractive power. Like to see the distance, you need different refractive power, and to see at the near, you need a different refractive power. So what happened in a multifocal, for the near, it has some kinds of diffractions. So due to that, it causes the near vision to be read. But due to this different diffractions, it causes the glare, and you have a and that is why the patient become unsatisfactory with it. In some jurisdiction, implantation of the multifocal IOL is a contraindication to the holding of a private or commercial pilot license or to a military service. Monovision consists of the targeting of the IOL-induced refractive outcome so that one eye, usually dominant, is optimized for the clear, uncorrected distance vision and the other for near or intermediate vision in order to facilitate both good distance and near vision when the eyes are used together. So basically, the concept monovision is that one eye is used to read far and the other eye is used to read near. Some studies show similar levels of functional near vision using bilateral distance optimized monofocal IOLs in comparison to the multifocal IOL. Conductive keratoplasty. This is some evidence that CK can impact a degree of multifocal functionality to the cornea. Laser-induced monovision refers to the use of laser refractive surgery to optimize one eye for the distance and the fellow eye for near or intermediate vision. So you use laser to make one eye to see far and the other eye to see near. So that is why it is used. Corneal multifocality. Several different approaches are under development utilizing a laser procedure to alter the shape of the cornea such that a bifocal or transitional effect is induced. Scleral expansion surgery results have been inconsistent and unpredictable, and this technique has not achieved sustained popularity. Intracorneal inlays commonly provides a substantial benefit in presbyopia, though in the past the biocompatibility of some material have been relatively poor and complications such as extrusion can necessitate removal. Laser modification of the natural lens. Research is going on into the use of a femtosecond laser to modulate crystalline lens elasticity. So this is a research basically that different to increase the elasticity of the lens capsule so that the eye can accommodate. Intracorneal inlays 8.16 for presbyopia A and B is showing refractive inlays, and the small aperture inlay utilizes pinhole effect. So basically inlays are a small refractive material that is used in the cornea to accomplish presbyopia. Laser refractive procedures. To settle any contact lens induced corneal distortion prior to definitive keratectomy, keratometry, soft contact lens should probably be discontinued for 2 weeks and a hard rigid gas permeable lenses for at least 3 weeks. Some surgeons suggest 1 week for each year of wear to date. So basically it is very important for the MCQ's point of view that you should remove before undergoing laser refractive surgery. You have to undergo few tests like corneal topography, and one must know that we should do not wear the contact lens for, because they changes the refractive surface. So one should not wear the lens for at least 2 weeks in a soft, and at least 3 weeks in a hard gas permeable lens. And some surgeons suggest, for example, if you wear a lens, contact lens, for like 1 year, you should not wear it for 1 week, before 1 week. And if you wear, what, for example, 10 years, you need to wait for 10 weeks to for the LASIK procedure. Laser in situ keratomyolysis. Laser or laser assisted in situ keratomyolysis. LASIK is a very common refractive procedure, the excimer laser, which can ablate tissue to precise depth with negligible disruption of the surrounding area, is used to reshape corneal stroma exposed by the creation of a superficial flap. The flap remained attached by a hinge to facilitate accurate and secure positioning. Repositioning. Myopia is corrected by central ablating, flattening, and hypermetropia by ablation of the periphery so the center becomes steeper. LASIK can generally be used to treat higher refractive errors than a surface ablation technique. So basically, you need to remember that what is LASIK. LASIK is basically you use excimer laser. What you do is basically, for example, this area, first you remove the epithelium of the cornea. When you remove the epithelium of the cornea, you put the excimer laser. What does the excimer laser do is that it will ablate the cornea of that side. For example, in case of the myopia, it will ablate the center of the cornea so that the center become flattened. When the center become flattened, it will, the myopia become less. Whereas in the hypermetropia, the periphery of the cornea will ablate, so the center become so this become flatter and this become steeper. I hope you understand. And then you reposition the flap. How many degrees are corrected by this procedure? Hypermetropia up to 4 diopter, astigmatism up to 5 diopter, and myopia up to 12 diopter depending on the initial corneal thickness. To decrease the subsequent ectasia, residual corneal base at least 250 micrometer thickness must remain after ablation. The amount of the tissue removed and therefore the amount of refractive error correctable is limited by the original corneal thickness. It follows the high refractive errors can be addressed only by intraocular procedure. So the corneal thickness is very important in this case. For example, after the ablation, the corneal thickness must be at least 250 micrometer. And before the corneal refractive surgery, at least 400 micrometer is required, greater than 400, so we can carry out the procedure. So it means if the cornea is very thin, then you cannot perform this surgery. You have to go for the intraocular procedures. In addition to the treatment of wider range of refractive error, advantages over surface ablation include greater post-operative comfort, faster visual rehabilitation, and more rapid stabilization of the refraction and milder stomer haze. The major disadvantage is the potential for the serious flap related complications. So what happened when you ablate the cornea with the excimer laser, then you place the flap pap because it was already attached by a hinge. Technique: a suction ring centered on the cornea is applied to the globe, which raises the intraocular pressure substantially. The ring stabilizes the eye and provides the guide track to the mechanical microkeratome, which is advanced across the cornea to create a thin flap. The flap can also be created using a femtosecond and recently a picosecond laser microkeratome. The flap is reflected and the bed reshaped, followed by the flap repositioning. So I told you earlier, you have to stabilize first the eye. You stabilize it by the suction ring, and then what you do is you place a keratome. It can be manual. When the manual keratome is used, it is called the simple LASIK, but when the femto laser is used, it is called the femto LASIK. And then the cornea is when the flap is raised, then you reshape the cornea by applying the excimer laser, and then you put the cornea flap back. Intraoperative complications. include buttonholing, penetration or amputation of the flap, incomplete or irregular flap creation, or rarely penetration into the interior chamber. So basically what can happen is that the flap can be damaged, like it can have a buttonhole formation. It can you can simply have the amputation, the flap separated from the cornea itself wholly, and other is like you can have irregular flap and sometimes a penetration into the interior chamber. Post-operative complication: tear instability is almost universal and may require treatment. Wrinkling, distortion, or dislocation of the flap, subepithelial haze with resultant glare, especially at night. So basically, dry eye is very common after any type of surgery of the eye, like corneal surgery. Corneal surgery. So you can have to use lubricants for a while. Wrinkling, distortion, or dislocation of the flap, and subepithelial haze is because when the flap is, you raise the flap and then you put the flap back, then there can be some amount of the subepithelial haze. Persistent epithelial defects can occur: epithelial ingrowth under the flap, diffuse lamellar keratitis. Sands of Sahara may develop 1 to 7 days following laser. It is characterized by granular deposit at the flap interface. Treatment is with intensive or topical antibiotic and steroid. So let's talk about the sand of Sahara. Basically, when you put the flap back, then at the interface, you can see the dotish like opacities. So this is called diffuse lamellar keratitis, and you treat it with steroids and antibiotics. Bacterial keratitis is layer corneal ectasia, frosty, occult or mild keratoconus, and low post-ablation corneal thickness are the major risk factor. And a careful pre-procedure screening should be performed to detect any predisposition. So post-LASIK ectasia is a term that is used when you ablate the cornea. The cornea can, if it's thin, it can become protruded. So that is why you perform corneal topography to see that is there any kind of keratoconus in the patient. If that is the case, then the refractive surgery is contraindicated. LASIK may cause transient symptoms of the dry eye and glare secondary to the subepithelial haze. Surface ablation procedure. Surface ablation procedure like LASIK photorefractive keratectomy employs excimer laser ablation to reshape the cornea. So photorefractive keratectomy is a different kind of procedure. Like you make a flap, but you do not you actually you debride the epithelium altogether. You do not you do not create any flap or anything. You just debride the epithelium, put the laser onto the cornea, and then you place the BCL after that. So there is no flap creation, and the patient is very discomfort post refractive procedure. Like LASIK photorefractive keratectomy, PRK employs excimer laser ablation to reshape the cornea. PRK is able to correct myopia up to 6 diopter, sometimes higher, astigmatism up to 3 diopter, and low to moderate hypermetropia. The main disadvantages compared with LASIK are the lower degree of the refractive error correctable and the slower epithelial healing with unpredictable post-operative discomfort. However, as a flap is not created, there is a lower risk of serious complications than with LASIK, including corneal ectasia and a late flap dislocation, and may be a procedure of choice for the patient and higher than average occupational or leisure related risk of eye injury. It is also suitable for patients rendered ineligible for LASIK due to the low corneal thickness. Other indication for surface ablation rather than LASIK include epithelial basement membrane disease, prior corneal transplantation, or radial keratotomy and large pupil size. So these are all the contraindication to the LASIK. So we perform the therapeutic photorefractive keratotomy. So technique is that the corneal epithelium is removed prior to ablation. So you just remove the epithelium. You do not make a flap or put it back. You just remove the epithelium and then you apply the laser. Method may include a sponge, an automated brush, a moil epithelial scrubber, and alcohol. Ablation of the Bowman's layer and interior stroma is performed generally taking 30 to 60 seconds in moderate system. Sophisticated tracking mechanism adjusts laser targeting with eye movement and will pause the procedure if the eye is significantly decentered. The epithelium usually heals within 48 to 72 hours. A bandage contact lens is generally used to minimize discomfort. Subepithelial haze invariably develops within 2 weeks and commonly persists for several weeks to months. So, subepithelial haze can also occur in this case. Diminished final visual acuity is rare, but there may be decreased contrast and nocturnal glare. Intraoperative application of mitomycin C, mitomycin LASIK, or M LASIK may reduce haze. Complication includes slow healing epithelial defects, corneal haze with blooding and halos, poor night vision, regression of the refractive correction. So the even after the you perform the refractive surgery, the myopia can regress back. Uncommon problem include decentered ablation, scarring, abnormal epithelium healing, irregular astigmatism, reduced corneal sensation, sterile infiltrate infection, and acute corneal necrosis. So these are just the potential complications that can happen after a PRK. So variations of PRK, basically all these refractive procedure are more or less same. You just, in some cases you just remove the epithelium, you put some other laser. So these are all things. A range of procedural variations with the corresponding varying terminologies has been described. For example, LASIK, like LASEK, laser epithelial keratomyolysis or laser assisted subepithelial keratectomy. Epi-LASIK, epipolis or epithelial LASIK. Epipolis is a Greek word meaning superficial. Modified PRK, advanced surface ablation, ASA or ASLA, and trans PRK, transepithelial PRK are variations of PRK that utilizes a variety of technique to reduce the discomfort and post laser haze and to speed visual recovery. ASA, which is the advanced surface ablation, and modified PRK are sometimes used generally to refer to all the surface ablative procedure. In LASIK, the epithelium is detached and peeled back after the pre-treatment with dilute alcohol. Laser is then applied and the epithelium repositioned. So in the LASIK, what happened is that you make a flap of an epithelium, and what happened then, you ablate the cornea and then put the epithelium flap back, and then you put the uh, um, PCL over it. Epi-LASIK employs a mechanical device, an epikeratome, to elevate a hinged sheet of epithelium with an oscillating blunt plastic blade, and alcohol application is generally not required. So in epi-LASIK, you use the epikeratome. Some recent reports suggest that healing occurs more rapidly if the epithelium is simply detached entirely without replacement flap of epi-LASIK. The entrance PRK epithelial ablation is performed with the laser. In entrance PRK epithelial ablation with the laser prior to the refractive ablation, reducing operative time and possibly confirming other benefit. So you can see that 8.17 is showing that laser in cytokeratomalysis LASIK elevating the flap, so the flap is elevated. B is showing the retroillumination, showing the wrinkling of the flap. C is showing the subepithelial phase. D is showing the epithelial ingrowth. E is showing the diffuse lamellar keratitis, sands of Sahara, and F is showing the bacterial keratitis. Corneal ablation during photorefractive keratectomy. So you can see the cornea is getting ablated during the refractive procedure. Refractive lenticule extraction. Refractive lenticule extraction is a relatively newer technique that uses a femtosecond laser to cut a lens-shaped piece of the corneal tissue and lenticule within the intact cornea. This is then removed via a LASIK style flap, or more recently using a minimal invasion 4 small incision lenticule extraction SMILE Potential advantages include less marked biochemical and neurological corneal disturbance than LASIK, and a likely lower risk of infection and other flap complications. Surface disturbance is minimal in comparison to the surface ablation. So what happened is, because in the intact cornea, so this is a cornea, you take a piece of the cornea, and that is called the refractive lenticule extraction, and you can do it by even a minimal incisions like smile, in which you mm, put a small incision and then um, take a lens lenticule extractions. So these are the smile procedure. So that's it for the cornea and refractive surgery part 3, and with that we finish our chapter 8. Thank you very much. We'll see you in the next lecture.